looking and seeing who's on and just making certain that I know who's here and just greeting you a bit. So Georgina, you're next to me on the top of my screen. Nice to see you. Jonathan, hello. Gawaha, nice to connect again. Scott, gorgeous to be with you. Tracy, thank you for joining from Vancouver. Miles from Nairobi, lovely. Annie from Essex, great, Henk. Thank you for joining from the Netherlands. I hope you're okay. But lots going on. Vicky, thank you for joining and for all the work with Nazim. Karen, thank you. Sarah, lovely to read many of your postings during the last week. Very interested, actually. Rob, thank you for joining from Toronto. Jane, hello. Nancy Walters, very special to be together and haven't seen you for ages. Thank you. Anna Pace, nice to see you. Magen Mutefa, thank you. I hope all is well in Gaborone or Habarone. NK Seti from New Delhi, Karen Kaplan from New York, Leah Marie, thank you for joining. And then Anne Hendricks, I saw some very interesting stuff from you this week. It's been great to be connected. Ad Spikers, thank you. Thank you for all you're doing. Paul Thomas. Paul is leading a whole wonderful initiative for really completely transforming general practice in the UK. Paul, it's special to see you here. And I hope that we can get you to talk. And if you can't stay on all the time, please let us know, because I very much want to hear from you about the COIN initiative. Joe Nichols, thank you for joining. Ian Boyd, great. Fawzia Rashid, I was taking your name in vain around the new year. What we've discussed about the Aga Khan Development Network and your involvement in climate change. I hope you'll talk today. Ian Boyd, thank you for joining. My brother William, great to see you here. Fruzan, nice to see you. Julian, great. Krishna, thank you for joining. Laura Obvious, thank you. You're part of the expansion of the 4SD work into food. Laura, thank you for being with us. Catherine Deland can't be with me physically today. We're in lockdown here in the part of France where we live, and that means that we are respecting that quite carefully. Kat, thank you for all you're doing. And then Carl Taylor, great. Carl Taylor, nice to see you. Can't see you physically, but it's great to be connected. Farhan Tazib, great, thank you. And Noemi and Karina, gorgeous that you're here as well. We're about 40. What I wanted to, and Jack Broham, thank you very much indeed. As with last week, I want to go through quite a structured sequencing of starting off with my view of what's happening with the pandemic, and then from that going into aspects of the response. In that, I want to refer to quite a lot of the discussion we've had in WHO, in the executive board, but also among the group of special envoys who met earlier today. I think that it would be very helpful to share with you what I'm picking up from the different envoys as they now navigate the pandemic in their different parts of the world. I'd like to focus a bit on diagnostics and treatments. I may not have as much in terms of radical new information to share as I would want to, but I want to create a space for going into more detail into diagnostics and their use, and into treatments and their use. And then thirdly, I want to talk about vaccines, vaccine availability, vaccine strategy, vaccine effectiveness. And in that, I want to talk about variants of the virus and how they are appearing and what their meaning is. I may have talked about the variants beforehand. And then lastly, as always, I want to talk about systems change, systems leadership. Very interesting to talk to people in the UK about what this is meaning for health systems in the UK, and perhaps thinking more broadly about elsewhere. Now, in talking about the WHO Executive Board, I do have to bring you up to date on some of the very interesting politics surrounding the WHO Executive Board, particularly the decision by the United States of America to stop pursuing its plan to withdraw from the WHO, but not only to be very active as a participant in WHO governance, but also the United States planning to join the Access to COVID Tools Accelerator and the COVAX initiative, and what this means. And that will require me to also look at some of the higher level geopolitics around all this. There hasn't been massive shift since we were talking last week. I think many of the things that we were surfacing last week will also come out this week, but at least I have a chance to continue to fashion it. We've done such a lot of work this week in different parts of the world. I feel that may be helpful. Again, if while I'm talking in my introductory part, you want to come in, please do so. I want to check just with one or two people. Paul Thomas, can you stay on? How long can you stay on for?
I can stay on for as long as you like, David.
Thank you very much.
What time is it intended to go on?
1 hour. We are 1 hour, and we slip over a bit, but we are 1 hour.
I can manage that easily.
Thank you very much indeed. That's absolutely wonderful. Fawzia, how long can you stay on for? Now, if anybody else is going to go off early, please just let us know in the chat, okay? Fawzia, can you stay on for the hour? Can't hear you. Okay. All right, well, on the pandemic and looking at the, Catherine Delan, I'm very, very keen that you unmute and turn on your video and jump in, especially as we've done so much this week together with WHO and so on, and I want to hear your voice. I'm being supported today by Florence Lasben, our Forestry Managing Director. She's sitting on my left, and she's scanning the chat lines, and also they've got the WhatsApp group open. Thank you, Fawzia. The pandemic. What am I seeing as I look around the world at the numbers? Terribly uneven. And I think that this is probably something that I want to stress more than ever. And I've been stressing it today a lot in my various discussions which I've been involved. When we look at what happens in a particular setting as this virus arrives and gets established, the distribution of cases with people who've got COVID tends to be very focused. You don't get whole areas with equal incidence right through the area, but instead very localized, often quite intense areas of illness, and then quite nearby, perhaps 20 kilometers away, you may get incidence much, much lower. It's very spatial and very focal, the way the outbreaks of COVID build up. And of course, there are certain communities with particular occupations or with particular patterns of living where you tend to get quite deep levels of infection, i.e. a density of infection, people quite ill, and so on. And those, as we've discussed before, tend to be poorer communities, tend to be people who work in very close contact with each other, people who live in very confined settings. And we're learning more and more about the relationships between income and social status on the one hand, and likely incidence of COVID on the other. But I want to stress to you that this very variegated distribution is really important, because it means that in order to understand where the virus is, quite a detailed analysis has to be done. In some places, they say right down to the actual postcode in order to understand incidence and distribution. But then at the same time, what we also have to do is to aggregate all the numbers from the different parts of a country into the national figures, and then the different national figures into regional figures into global figures. And of course, an awful lot of detail gets lost in the aggregation. And when you get these bits of information saying, there are 36,000 cases in the UK yesterday, that's not really telling us what's happening in the country. And in particular, understanding, how the distribution is changing is hugely important when it comes to planning a response. And those of you who've been joining these briefings on and off will know that we are really focused here on the importance of local data, local responses, local systems for engaging multiple actors and ensuring that there is a local coordination. It doesn't mean you don't need to have a national strategy and national data and national directives. What you really need is to join the national and the local together in a really, really strong bind. I was talking to somebody who's been working in the UK on things like test and trace and so on. And this person described to me the real effort that was made after it became clear that the national test and trace system was just a little bit too slow and not precise enough to get really down to the local level, how much the test and trace team actually invested in trying to connect between the test and trace central and different local authorities through the district public health or through the DPHs. And, it's quite interesting because it took time to do that. It required recruitment of a lot of different people, and it required setting up special systems to link together the centre and the local. And you kind of say to yourself, well, all that, when you're reconstructing systems in the middle of an outbreak and pandemic response, in fact, you're losing time because you're having to invest in capacity building, whilst at the same time, make sure the system is working, whilst at the same time, respond to evolving priorities. And that's why I think one of the big things that I'm going to take away from this stage of the pandemic is we've got to keep working on these interfaces between local and national, and of course, interfaces between national and global. Do you remember, some of you, when we were talking last year about the 7 different essential aspects of getting systems right for dealing with this pandemic? I'm always careful when I talk like that because it implies a kind of bit of arrogance, but we did say connecting together the different levels, a neighborhood level, where we were talking about community health watches and so on, through to the more then the sort of district level, and from the district level through to the national level, and the importance of local authorities and chief executives of local authorities connected with directors of public health and general practices in pulling together this local capacity. We've always said it's the connections between the levels that make the systems work well or not. And we see that in the US, where day after day I'm receiving reports of considerable gaps between what's coming at the federal level, what's happening at the state level, and what's happening at the county level. And so perhaps this applies in quite a number of countries, not just in the UK or in France or other European countries. So keeping on talking about this, I wanted just to stress that in our work on understanding the pandemic, we are realizing that the analysis has to be local, the response has to be local, that it has to be put into some national strategy, and without that we get stuck. So continuing on with the pattern of disease, as I said last week, there are certain places in the world where things have got particularly bad. They don't stay bad forever, but they get bad for a bit. So the southeast of UK was bad. It seems to be slightly softening, but it's still pretty bad, according to my colleagues. And what are the indicators? Well, they are obviously case numbers are beginning to fall, but hospitalization still high and death numbers still rising. You remember there's always a lag of about 2 to 3, even 4 weeks between case numbers and death numbers. And so the situation in Southeast UK is still particularly horrible for those involved in it, but with some relief, we can say that it looks like the case numbers are coming down, day-on-day reductions over the last week. which suggests that perhaps that intensity in Southeast UK may have reduced. Does that mean everything is sort of going back to normal? Absolutely not. All that it means is that the combination of movement restrictions and public exhortation has definitely led to a reduction in the number of contacts that each person are having. And that reduction in the number of contacts is associated with a reduction in incidence levels. But the moment the contacts increase again, we know really well, because we've seen it before, the cases will pick up again. And it's not as though the numbers have come down anywhere near zero. You just have to look in the regular data check in the Guardian. It's still running at 36,000, so it come down 10,000 a day, but it's not come down enough. And perhaps this is something that's of real concern in Western Europe at the moment. Despite quite strenuous movement restrictions, the numbers have not come down towards zero, and they've not even come down as though they did after the last lockdown. What does that mean? And of course, the debate is always there. Does that mean we've got a tighter lockdown to try to get the numbers down further? Or is that actually politically a non-starter because we've got to try to keep economic activity going? Same sort of challenges in France. Very scattered distribution. It's not even. Very big concerns about the fact that the numbers have stuck a bit. They're not as high as they are in the UK, but they've not come down to zero. And what options are there for government in thinking through what's going to happen over the coming 4 to 6 weeks? We'll be talking about all that. That's still to come. But I just wanted to say this patchiness and the fact that the numbers are still quite high in different parts of the world, despite efforts to restrict movement, is a problem. Inside all this, we have more transmissible variants emerging. The B117 variant, current name in the UK, more transmissible. What does this mean? Well, the current view is that that's certainly changing the transmissibility, but it does not have any impact on the basic strategies to try to control the pandemic. So let's move to other places where things don't look too good. Amazonas in Brazil. That's that part of Brazil that's right in the middle of the Amazon area, Amazon Basin. The big city there is called Manaus. And the story for Manaus is very high demand on hospital care and extreme shortages of a number of things, PPE for health personnel themselves, not there in full quantity because of illness or need to isolate. And then in addition, a really major shortage of oxygen in the hospitals, which has caused quite a lot of anxiety in Brazil and even in Latin America. Southern Malawi, there things seem to be particularly nasty, also in parts of Zimbabwe. Two cabinet ministers in Malawi dead, one cabinet minister in Zimbabwe dead, but a lot of other people suffering. What's happening there, and why is that particular part of Southern Africa looking to be so serious? I'm sure you've got other examples that you can share from near you of where there seems to be just a really unpleasant hotspot. When it comes to response, I today spoke to Maria van Kerkhove of WHO, who is the super sharp epidemiologist who's focusing on steps to be taken to reduce risk. And I said to her just straight up, Maria, is there any evidence that a different pattern of responses are necessary to react to the emergence of new variants that are perhaps causing some concern? New variants in the UK, new variants in South Africa, new variants in Brazil, new variants in Southern California. Note that the new variants seem to be in these places where we got particularly nasty situation. I said, is the strategy different? She said, absolutely not. We've got to continue with the same non-pharmaceutical measures that we know work. And why not just keep going with them? What are they? Physical distancing. Let's just remember the best way to stop yourself getting a droplet from somebody who's got this virus, whether they're speaking and spitting like I am, or coughing, or sneezing is that 2-meter rule. Stick with it. Don't just think, oh, well, I'm seeing my gran and I've got to go up and give her a hug and it doesn't matter if I can just go and be close. You know, we say 15 minutes with somebody who's got a lot of viruses is not good. And we've got evidence that sometimes it's even a more rapid contact, even just passing somebody inside a crowded shop or in a bank manager's office or something like that. You know, don't think that it's always going to be, you've got to be more than 15 minutes with somebody to stand the risk of picking up the droplet. In certain circumstances, there's evidence suggesting that even more rapid contact could be associated. Rare, but it's been noted. So physical distancing matters. Public transport, physical distance. In an office, physical distance. When you're with relatives at home, physical distance. In the workplace, physical distance. In a restaurant, physical distance. At a party, physical distance, if you're going to parties. Number one. Number two, face coverings. The WHO people believe that a well-fitting cloth face covering is good enough to really reduce the risk to yourself if somebody else has got virus, or to others if you just by accident find that you're meeting people while you're secreting virus. Now, there are some who say, well, cloth face covering is not good enough, this sort of thing. We've got to shift onto more surgical mask face coverings, the ones that look a bit like this, the sort of thing that your dentist wears when poking around in your mouth. And indeed, in France, they're now recommending a shift to the surgical masks from cloth masks, which is super interesting. And then I'm hearing even in some countries, they're thinking of suggesting moving to more sophisticated masks than that, what's called FP3 respirators or similar. So I discussed that with the WHO team, and they're saying, well, yes, they know that all this is going on, but they're saying we're actually asking countries who are recommended changes in masks to be in touch with us today to explain why. That's what they can do in WHO. They're able to ask for explanations. Why are you recommending changes in face masks? So that'll happen this afternoon. But in the meantime, it's what I said last week, but I want to say it again. Yes, the type of mask might be quite important, but the most important thing is how you wear your mask and what you do with your mask. You know, is it fitting snugly over your nose? Yes or no? Are you carrying it below your nose? Very bad. Are you carrying it below your chin? Useless. Are you fingering it all the time? Not good. And all that stuff about mask etiquette is probably more important than type of mask. But you'll see lots of people writing articles in newspapers and so on about type of mask. No doubt there'll be a lot of talk about it. As far as I'm concerned, just wear it properly. Number three, hygiene. Now, in most times, we think surfaces are not the primary means through which the virus is carried. But there's plenty of evidence that hand washing, cough etiquette, and surface cleaning can make a contribution. And some people are really pushing this very, very strongly indeed, particularly in factory settings where you might get quite a lot of virus on the surface. I'm reading reports from China that they think that some of the recent outbreaks are to do with environmental contamination. And so I am going to say there is no doubt certain types of locations where you get a lot of environmental contamination. Examples, healthcare settings, residential care settings, factories like meat factories and so on. These can be high contamination zones. Hygiene, good. Over hygiene, unnecessary. And particularly do too much mucking around cleaning surfaces, it distracts you from doing other things. So make sure the hygiene is there and get it right, and particularly keen on doing it in places where there is thought to be a real risk. Number four, isolation. One of the reasons that I'm going slowly through these is that there are things that are slipping. Isolation has not been done well in Western Europe. But you talk to friends who've gone to Singapore, you talk to friends who've gone to Hong Kong, they'll give you a different story. They arrive and they have to go into quarantine in a hotel. They're kept under close supervision. They break the close supervision, they get into deep trouble. Look at Australia. Australia really working hard with isolation in relation even to small numbers of cases. The isolation has to be strict. The isolation has to be before people have got their test results. When they think they might have the COVID, they should go into isolation. And if there's a rule about going into isolation, if you're a contact, then you must do it. I'm very interested that British government talking today about £500 grants to people who are having to go into isolation, who've got COVID. That's a good thing. I mean, thank goodness it's there, because asking people to go into isolation and making them make do on £94 a week sick pay when they're normally earning £400 or £500 a week is asking them to take a huge hit. And no wonder people go on coming to work. No wonder friends do not do mentioning the names of their friends in contact tracing and so on, because they're worried they might create a situation where their friends are going to have a big cut in income. This point about income and earning loss through having to go into isolation was very, very important. And then I do want to add in one more thing, which is in these winter months, we've got to be careful about enclosed spaces that are not ventilated, where there's a possibility that people are sitting for several hours or sleeping for several hours in close contact with others. Because there's no ventilation, real risk of buildup of particles. That also is something we need to think about all the time, is ventilation. Anyway, I've given you that, and I want to say that Maria Van Kerkhove and Tedros and all the team are saying that's what you need to do, whether you're dealing with new variants or the old, more classic COVID, is to do it all on these non-pharmaceutical interventions, and then back it up with really good quality local level public health to help to interrupt transmission and to maintain isolation. I wanted to say that all this is proving to be quite challenging, because we are still troubled with the lack of decent diagnostics. The rapid antigen tests are useful, and we want to encourage people to use more of those, use them properly. They're not perfect, but they're much better than nothing. All I'm hopeful for is that we will get more and more reliable, rapid diagnostics that can be used without electricity in situations where there is some degree of professional action. So it's not people using them completely on their own at home. These will be necessary. Some of these rapid diagnostics may be insufficiently sensitive unless there is some sample preparation before the sample is put into whatever is used for the rapid diagnostic test. That does mean that they will probably need a professional supervision. I don't think we will have complete free and easy do it at home on your own type tests for everything. You may have those for antibodies, but I think that the tests for virus or bits of virus are going to stay being tests that will require some degree of professional supervision. New treatments coming on board. Well, everybody is getting quite excited about looking at drugs that are already in use for other reasons to see if they could be repurposed, because everybody knows that we've got still some need for effective therapies. And there's beginnings of talk that there may be more therapies coming on stream, not therapies for every single person, therapies for certain patterns of people with COVID. And I'll be keeping you briefed on that as I get more information. So we're now moving into the phase where there's an awful lot of conversation about vaccine. An awful lot means an awful lot. I'm sure if I worked for social media companies and I did a search of messages on Twitter or voicemails or whatever for mention of vaccine, we would have had a huge upsurge in mentions of vaccine in the past 2 or 3 weeks. It is the defining political issue of the first part of 2021, basically an anxiety that people are not going to get access to vaccines that they need, and that a big amount of political action by leaders looking for any possible way to get access to vaccine, to try and jump the queue and to get more, and so on and so forth. I mean, the big problem is that only a small number of vaccines have actually been through their phase 3 clinical trials and have then been to WHO for some kind of emergency use authorization and good manufacturing practice certificate. But only one has come through, and that is the Pfizer-BioNTech minus 70 degrees storage vaccine. The other vaccines, like the Moderna vaccine, the AstraZeneca vaccine, the Sinopharm, which is from China vaccine, or the Sputnik 5 vaccine from Gamaleya in Russia, that's the current group of vaccines that are being talked about a lot. Well, those four, Moderna, AstraZeneca, Sinopharm, and Sputnik, have not yet been given emergency use authorization status by WHO. For some of them, the data have only just reached WHO. For others, the data have not reached WHO, which makes it really difficult for them to be discussed as possible vaccines for use in any global strategy. But meanwhile, that's not stopping the manufacturers of some of these vaccines from going into bilateral arrangements with specific countries, or indeed with the African Union, despite the fact that their vaccines have not yet been through the WHO process. It does make you scratch your head and ask yourself, what is going on? How come companies are not putting all their data through the WHO verification process, yet meanwhile are going around and doing bilateral deals with big countries like India and South Africa, smaller countries as well, or with regional bodies? And Tedros himself was very public earlier this week, saying of the three things he's really asking for, one, would countries that have got spare vaccine give vaccine over to COVAX so that it can use that? Two, would companies provide all their details of what their product is to WHO so that it can go through the emergency use authorization process? And number three, would companies please tell WHO what, even confidentially, what deals they're doing with individual countries so that WHO knows what's in the pipeline, so that then that helps WHO with prioritizing what will be quite a big rollout of vaccines in the coming weeks and months, and to make sure that there is some response to need. And that third part is something, of course, the companies don't want to do, because WHO also wants to know what's the pricing in some of these deals, because otherwise it's really hard for WHO and the bigger COVAX initiative to have any chance of being a major player in the system. And that all that happens is the companies go backwards and sideways, and we end up with all the challenges that I've just talked about. There is an issue. Some countries are saying, like Norway, what's the purpose of vaccine now? Answer, protect people who are most at risk. Old people, people with comorbidities. Other countries are saying that they're going all the way to try to get to full population coverage, i.e. all the over 18-year-olds within the next few months. India has gone for a full population coverage target. France has said full population coverage by the end of August, assuming the vaccines are available. UK is definitely going for wide population coverage, though I don't have a target day in my head. US has gone for 100 million within 100 days, moving towards full population coverage. If you go for full population coverage, given the amount of vaccine that's around in the world at the moment right now, big shortage, what's it going to do? It's going to suck all the vaccine into the rich countries, including giving it to people who have fairly low risk profile. And it's going to mean that the vaccine for health workers and others with high exposure in poor countries is going to be very low. And currently only about 30 or 40 doses of vaccine have been used in poor countries. Rather an awful lot more have been used in the 40 or so rich countries that have started their vaccination. I mean, we are walking headlong into a terrible inequity crisis. But if the rich countries are going to try to use the vaccine that's available to pump forward fast as they can with moving towards full immunization, that's really going to make a bit of a mess. And by the way, the use of vaccine to try to stop the pandemic is a little bit unwise, because at the moment there is no evidence that any of these vaccines actually have a direct impact on transmission. All the information that we got is whether a vaccine reduces severe disease. So there's some pretty big inconsistency in some of the vaccine policies, and we're all watching that. In the meantime, the variants are coming along. There are more and more mutations that turn into variants. So these variants happen to be in the places where there are quite high incidence figures. And of course, there's a big question as to whether or not these variants represent a phenomenon called immune escape, which means they can escape from the antibodies that are formed as a result of the vaccines, and that will be a major problem. Keeping an eye open for immune variants, a huge job. WHO now got a major surveillance system all over the world called the Virus Evaluation Working Group. It's not easy work, and it's very, very important. Lastly, I want to keep stressing that dealing with vaccine inequity, dealing with the national-local dialectic that I talked about earlier, trying to maintain the focus on non-pharmaceutical interventions to get on top of the pandemic. This requires global leadership like never before. I've lamented some of the fractures in global leadership. So what excitement there is that yesterday in the WHO Executive Board in the morning, Tedros was able to announce that one of the executive orders that Mr. Biden was releasing as part of his first set was to stop the plans for withdrawal from WHO, and that Dr. Tony Fauci addressed the WHO Executive Board yesterday. Very, very positive indeed. I mean, I think this is just wonderful news. Dr. Fauci is a superb leader. And so there's a real chance of US leadership, especially, as I said at the beginning, because they're coming back into COVAX. I hope that this will lead to the opportunity for Mr. Johnson, as the chair of this year's G7, already planning a vaccine summit, to team up with Mr. Biden and other G7 leaders and really start to focus honestly on the question of vaccine efficacy, vaccine equity. It doesn't have to mean that rich countries say, oh, well, we will get all our vaccines through COVAX and wait our turn. No, I mean, if they are rich and if they have been involved in developing vaccines, no doubt they will want to benefit from that. But let's at least get some agreed approach to the equity challenge from the leaders of the G7 or of other groups. And that's where UK and US are hugely important in the G7, and Italy, who are already planning a vaccine summit in May. They also are really important. So all this, watch this space. I shall be quite active on trying to help ensure that leadership, international leadership, is strong. Thank you for the chance to speak. Twee, would you like to do a quick quiz, and then I'm going to do an effort to involve many people. And I would like just to give note that Paul Thomas, I'd like you to come in early, Paul Garner and Chris Lara, if you don't mind. Over to Twee.
Thank you. So a little break here, intermission, you could say, where we have a poll going to run with 3 questions. Now follow through with me and answer as we go along, and then at the end I will immediately share the results. So question 1, what is English physician John Snow most well known for? Discovering cholera was a waterborne disease, developing the polio vaccine, or discovering penicillin? Question 2, in just over a week, on the 30th of January, it will represent 1 year since a PHEIC was declared. What does it stand for? A public health emergency immunization campaign, a public health emergency of international concern, or a public health and environment international call? And then the last question is not a quiz, actually. It's for us to get to know you, but from a different perspective than we did last year. It's a multiple choice question here. Have any of you had a COVID test? Have you been contacted or notified about exposure, contact tracing? Have you been requested to isolate because of exposure? And then lastly, have any of you had the COVID-19 vaccine? So just a few more seconds. I'm experimenting with the poll. A lot of these questions come from your feedback from our previous surveys, and we'll keep experimenting with them to make sure that you're enjoying them and learning from them as we go along. So I'm going to end that poll in 3, 2, 1.
3. If it's none of the above, your last question, number 3, I'm none of the above and I can't submit it.
You're not able to submit it?
No. Question number 3, none of the 4 I fit, so I cannot, you need to add one more item, none of the above. Otherwise you can't submit it.
Oh, I must not have selected that correctly. But let's have a look at the results that came out and I'll make sure I get that right next time. For number 1, what is English physician John Snow most well known for? It is indeed correct. 81% of you chose discovering cholera was a waterborne disease, and he did this by working with the community in Soho, London, connecting with different people to help gather the data and figuring out that the source of the cholera was a water tap in the street. So a fascinating story there. 3rd of January, the answer is next week will be the 1 year since a public health emergency of international concern. So 70% of you got that right. The definition of that, it's a formal declaration by the World Health Organization, which means that we require a coordinated international response. And question 3, yes, apologies, I must have set this up incorrectly, but it does show 95% of you have had a COVID test, which is much higher than I was predicting. Next week, I think I'll try that again and I'll do it correctly with multiple responses. But thank you very much for joining in.
Thank you. Paul Thomas, please. Just any reactions to any part of what I said, perhaps in a couple of minutes, if you can do it. And welcome to you and thank you for your leadership on transforming the face of general practice in the UK.
Thank you very much, David. I run a network of around 100 people who are distinctive and they understood pretty much everything you said, David, which is going to be an unusual group of people, particularly about the importance of linking the local with the district with the national, and particularly about how you actually do it. Excuse me, cough. One of the really important things we've learned here is that it's very important to let people go at the pace that they can go at and find these things for themselves, because the theory and practice of comprehensive integration is really very difficult or unfamiliar, not necessarily difficult, but very unfamiliar. So not that many people are skilled at it, and those who are tend to get outnumbered by other people and start feeling defensive. So what COIN is, and COIN stands for Community of Integration Network. I'll circulate my email address and the name at the end so that anyone who wants more information can get in touch. Is in a way a mutual support group that's helping people who are trying to work out these ideas in a way that they can hold on to the ideas they wanted to, and also be more ambitious than they may want have tried to be. And this is particularly important in the UK because the present government policy is to develop a thing called primary care networks. These are geographic areas of around 50,000 population where general practices and other community services are meant to have an important role for health and care. Integrated care for long-term conditions, let's say diabetes, exemplifies the district, the local district and national, but the horizontal integration is for health as well as disease, leads to unfamiliar ideas like linkage with public health and primary care, with voluntary groups, with schools, with all the things that were said in Alma Ata all those years ago, but have never been fully actioned. So what COIN is trying to do is to work with people who are leading in those areas and hold their hands to make these things stronger. Primary care networks, of course, are mostly dealing with things of medical concern. So we're working with people who can expand that vision to think horizontally as well. We're calling this community-oriented integrated care, to mean that the integration efforts are meant to come at local level. And we're particularly talking about how thinking about this at this scale challenges a whole set of concepts like the nature of evaluation, the nature of leadership, the nature of reality, the nature of health, and how one can lead that. So, for example, that would lead to ideas that when Darwin said the survival of the fittest, he meant the survival of the most adaptable, that the natural state of society is multiple co-adaptation. So leadership, naturally, is a sense-making facilitative process that helps people to co-adapt and listen to each other in a more effective way. And evaluation is not of the positivist scientific tradition, but follows Gruber and Lincoln's ideas of a fourth generation evaluation that says, firstly, that research and evaluation is a snapshot of more complex stories in evolution. And there are different paradigms or different lenses with which you can look at such evaluations in complex situations. And if you want to do this effectively, you need to use all three: critical theory, constructivism, as well as positivism. I could go on a lot longer, David, but I suspect my 2 minutes is up.
Have you put, I think there are many people here who would very much enjoy being able to connect with you. Thank you, Paul. Thank you, Paul Thomas. Can I go to another Paul, Paul Garner, who just to want to hear how you're doing. Paul Garner has been very open about his long COVID, but is now continuing.
Back in the game. I'm back in the game, David.
There you go.
So there's, I want to make 3 points. As you started with long COVID, I'll start with that. So I'm pretty convinced that most people with long COVID have chronic fatigue syndrome, ME, but because of the stigma associated with this and other associated pathologies, it's only just filtering through. But I think that's going to be a discussion in the coming months. It really has got all the post-viral symptoms, and I met the Canadian ME/CF chronic fatigue syndrome criteria, which is the most strict one, and most of the people I see on the books do. So that's part of the nature of chronic fatigue, is this post-viral syndrome, but there's other stuff going on. The second thing was to say, I support what you say on vaccines. Obviously, they've been tested in trials on morbidity, mortality, but not on transmission. And obviously they're going to have an impact on transmission, but we saw with HIV drugs disinhibition, and there is going to be a risk that people will feel safe and drop the other factors. And we just have to keep that in mind. Yeah. And then the third thing to say is, you talked about treatment drugs and ivermectin. I've just actually been going through all the trials, and the evidence, there's so much hype about this. It's the chloroquine story all over again. We do really need to breathe and stop people in South Africa injecting their patients with animal preparations of ivermectin and so forth. The panic and part of the hype, I am embarrassed to say, is the result of academics over-egging some of the materials. So just to be careful with ivermectin. Thank you for giving me the opportunity to talk.
And Paul, he and I know each other because he's leading part of the Cochrane collaboration, which is our whole effort to try to bring together all the results of studies that have been done to establish whether there's evidence for particular therapies. So it's really great that Paul has brought up the fact that he's been, as part of his work, looking at all the data on ivermectin, which we'll talk about in a second. Chris Lara, Duke University. Chris, are you there? Where's your vid? Here you are. Chris, to everybody who's in the United States, just for 5 minutes, let's just have a real sense of moment with you. Chris, how have you been feeling? Over to you.
Thank you, David. Hi, everyone. From here in the North Carolina, the Research Triangle. Well, we have this week what can be defined as a week of relief for many reasons, but more importantly, I think the new president has made clear that his priority is to deal with the virus. So the narrative has changed dramatically. It's a 180 degrees change in the way he expressed the concerns and the priorities of the government. I think beyond the vaccines, the 100 million vaccines in the first 100 days, and beyond the joining back WHO and playing a role as a leader in this multilateral system, I think the most important is telling the truth to people. He was clear on the speech, in the inaugural speech, that the worst days are coming and people have to be ready. But the most important part, from my point of view, is telling people that everyone has a role to play. And definitely, scientists up front. The briefings are very important to keep people updated on what the government is doing. And the third thing that I want to highlight is the change in the way the response is going to be conducted. From the strategic level is going to be centralized from the federal level, and the operational part, like for instance, distribution of vaccines in local pharmacies, that's very important because then it's a support to local governments and empowerment of local governments to respond. So these three aspects for me are a sense of huge relief for everybody.
Relief. I didn't get it right at the beginning. Are you in North Carolina right now or not?
I'm in North Carolina, yes. Here.
Yeah, good.
Good.
Thank you very much indeed. Lovely to hear from you. Thank you for sharing what you sense is quite a major change in strategy. I just wonder whether Karen Kaplan, here you are, you've joined us. I don't know what time it is for you today. Probably it's at a reasonable time compared with usual. How are you feeling, Karen, after the ups and downs of the last few months?
I'm feeling fantastic. I am so happy. I am beyond ecstatic. I am in some sort of like dreamlike state of normalcy and steady. Dan Rather said this word today, steady. It's so peaceful. I'm going to start to be able to sleep again sometime. I'm betting even by this weekend. But I'll just talk quickly. There's some really incredibly positive things, which we already kind of hit on last week, you know, with COVAX and Fauci saying it out loud and, you know, the letters coming and whatever, but, and Sam Power, Ambassador Power.
I forgot that. Samantha Power's got the head job at USAID. Excellent.
Yes. And actually I was tweeting with back and forth with James Chow earlier today, talking about the people's vaccine, which is, I think, because yesterday we hit more than 1 million. I don't know if Chris Lara, if you read that news flash once we got on this call, but we actually did more than 1 million vax yesterday.
Yes.
So they're thinking, you know, if they're going to hit more than 100 million in 100 days, they should go for a bigger amount, which is great, except for I'm like, well, I want to put pressure on the pharma. I want pharma to have a reckoning in 2021. I want equity for all people. One of the things that's different in just 2 days, which is kind of funny, but the media vacuum in America, where that vacuum occurred, communication was filled by conspiracy theorists. And now that we will be getting daily media briefings, Monday through Friday, with Fauci and others, we'll have 2 or 3 of them this afternoon, things will change. That media, the communication, I believe we'll honestly be able to get through to more people. Not the fringe people, but more of centrist to middle left, middle right, or whatever. I don't know.
Thank you very much, Karen.
Thanks.
That's beautiful. I think it's super important what you just said, that the infodemic kind of comes into the space, and it may well, my friends in WHO tell me that they think the situation is changing, particularly with the shift in global leadership. Thank you very much indeed.
Woohoo.
I'm just gonna, Rob Tyree said, have we any news on ivermectin research? Rob, I hope that what Paul said is some help. Catherine said that she's got something to share, but I agree that it's a bit difficult, the situation that doctors are in when the endorsement changes. Lynn Aiton, Lynn, where are you? I'm just looking for you on my screen. I can't see you. There you are. Thank you, Rob. Lynn, I can't see you. I don't know whether you're still here, but you say, what could be done to develop vaccine which is as easy to deliver in a person's home as the flu jab? I think this is well possible. I was talking with Samir Swaminathan, who's the chief scientist at WHO, and she said, you know, the vaccines you've got at the moment are just at the tip of the iceberg. They're the ones that have come through quickest, but there's more than 100 vaccines being looked at, including some that can be administered nasally. The situation may change dramatically in about 6 months. I think that the present is a bit tricky because we're just in this terrible supply problem. Yusuf Gottlieb, thank you, Yusuf, for your writing. And there you are, I can see you. Can we assume that the data we're receiving, especially from underserved countries, sectors and regions, is accurate? Answer, no. I mean, I know full well that there are big gaps in these data. And I agree that I'm too am concerned about the global south. I mean, I give you my view of what's happening, but I know it is incredibly partial. And all of you, please keep sharing. I mean, I've benefited so much, for example, from Joe Nichols and Miles and Zara sending their messages from where they are. And it's because Joe also covers what's happening across the border. She's able to give me lots of very helpful information. Sometimes just the tiniest snippet, you can add it to other things and it gets really, really good. Now, Jonathan Fitzsimon, I hope I've addressed this a bit. Some countries are stratifying their vaccine strategies and going to people over a particular age cutoff first, then people in residential care homes, then people in other essential services. Ireland has got a very definite approach to this, whereas other countries perhaps are being a bit more open about it because they just want to get the vaccine out. But let me tell you, most countries and most communities are going to those most at risk first. Now, Jonathan also says that Einstein said the definition of insanity is to repeat the same thing and expect different results. And he said, we've been talking about distancing, masks, hand washing for ages. I'm just going to say that I actually think we've got to get better at communicating this stuff and move from an average of 60 to 65% compliance up to 90% compliance. That higher level of compliance is key for at least most of the effort to get on top of this pandemic. The second part is to interrupt transmission through good public health measures. Beat Meyer says, why hasn't the uptake of contact tracing apps been better? He says his point of view is the marketing wasn't enough involved in preparing a pre-launch. What do I think? Well, I've just said contact tracing is two things. It is the app and it's the physical part of contact tracing, including the telephone, and combination is absolutely key. Annie Felton, we need more open local discussions, especially on vaccines. How does the NHS talk to us? I totally agree. I think there need to be COVID dialogues in every locality, multiple stakeholders coming together and being open about it. And I truly believe, Annie, that there's something in what you're saying. Lastly, Gawaha Atif says, what are the prospects of increasing vaccine production? Answer, huge. Why has AstraZeneca not been approved in some countries like Canada? Because there were some issues, I believe, with the phase 3 study. There were different dose regimes used, which meant that not all regulators are comfortable with that. And that's led to some delays in some places. Of course, the UK MRHA has gone a little bit faster, but the WHO certainly has not yet received the material that it says that it needs from the manufacturer to give it an emergency use authorization. Watch this space. We'll keep talking about it every week. Jack, could you show us the illustration, please? Thank you. There you go. I think that looks absolutely fabulous. Absolutely fabulous. And there you are, Paul. Coin gets a good mention in the top right-hand corner. Excellent. Thank you very much indeed, everybody. Twee, is there anything else you want to say?
That's all. Let's keep the conversation going on our LinkedIn community chat group. We'll see you there, or next week, Friday morning at 8 a.m. Central European time.
With that, we need to say goodbye. We hope that you find that the approach that we use, with a lot of focus on information, helped hugely by the enormous amount of briefing and mining that my colleague Catherine Deland does. I've lost her, but she is so important in this operation. She spends, are you in your garden, Catherine?
I have put a nice background up because I have managed to make an absolute mess of my office. I'm switching rooms at the moment, sorry.
Thank you very much. So Catherine really is offering the most authoritative summary that I get hold of all the different vaccines and so on. I'm very happy if there are major questions and areas where information is needed. This will can push us to, we've just been so busy recently, we haven't been putting reflections and so on narratives onto our website, but we could easily be putting some up-to-dates on some of these things. If you want them, just let us know. Loy Rago says he wants to see the image again, and I think we should do that. Could we have a copy of Catherine's report or an email? Yes, I will work with Twee to make sure that Catherine's material is available on the 4SD website. It's something that I think it's time to do. With that, I say goodbye to everybody. Thank you for joining us. Stay connected in whatever way you can. And as Tracy has said, safe good week, we would like to say